Thank you, Deb, for that kind and generous introduction. As Deb said, I'm Claire and I work for Turning Point as the Chief Operating Officer. And I'm going to use my presentation today to look back a little bit to the origins of harm reduction, to where it came from and why it was so important. And to use the opportunity to talk about Turning Point as we turn 60, as Deb said, and to look back through our own archive around some of the innovative work that we've been involved in. Because as Deb again said, there has never been a better time for us to come together and look and learn actually from the past at what worked. I'm new to this clicker, so bear with me. So I can't believe I've allowed this photograph to be included first and foremost in this slide deck. I'm horrified. But I'm really proud actually that my career started in Liverpool, which lots of people say is the home of harm reduction, and I would agree with them. That was me in my early 20s before I found a hairdresser, and I was working at the time at Liverpool University as a research assistant, and I was asked to go to somewhere called the Maryland Centre to interview people who use that centre, people who use drugs. And that's the building itself for those people who might have seen it on Hope Street in Liverpool. And it was a phenomenal place. It was the first large-scale needle and syringe exchange programme in the country. And I was blown away by the passion and the commitment and the compassion, actually, that the staff there had. And the resilience and the kind of, the drive that people using the service had to be safer and for their friends and family to be safer. And when I finished the piece of work I was doing, I didn't want to leave. I wanted to stay, and I did stay on as a volunteer on the outreach team and in the needle exchange. And my dream job was to work there. And I was really lucky that I got offered a job as an outreach worker. But it was on the proviso that I passed my driving test a week later. And unfortunately, my interpretation of the highway code was slightly different at that time to the examiners, and I didn't. So that job wasn't for me, but I did find a different way into the sector shortly after. The Maryland Centre really started something called the Mersey model of harm reduction, and it started with the opening of the centre in 1986. And it was really controversial at the time, providing clean injecting equipment for people who use drugs. It always struck me as being pragmatic, but it wasn't at the time. It wasn't seen as the thing to do. And it was developed because of the crisis happening across Liverpool. Sky-high unemployment, heroin use rising, and HIV rates going up. And because of the action taken, because of what Liverpool did with the Maryland Centre, and the Mersey model, HIV rates were kept lower than 1% amongst injecting drug users, which is one of the lowest in the country, and that's despite the fact it had one of the highest numbers of heroin users. I'm going to play a video in a second, and it's somebody that you might have heard of, Professor John Ashton, who was one of the people who helped set up the Maryland Centre at the time.
Behind me here is the site of the Maryland Centre in this building on the corner. This is an iconic building in the history of harm reduction globally. This is where it all began in 1986, where the first large-scale syringe exchange program began.
We followed American policies for so long now, stamping down on drug users, heavy sentences, and ignoring drug users' problems. Now, with the advent of AIDS, we've got to change the way we think about drug users. What AIDS means is that we have to show people less dangerous ways of using drugs.
The philosophy that we developed was to make contact with drug users, to maintain contact with them, and to establish a therapeutic relationship so that as and when they were ready to make changes in their behaviour, they would do it. They weren't being forced to do it. And they weren't being criminalised, as was happening in many other places.
Here, what we're trying to do is keep drug users as healthy as possible until they want to stop using drugs. You cannot force people off drugs. Teaching people how to use drugs is not a demonic, evil thing to do. It's a way of saving lives and keeping people healthy.
We were able to bring together the police, the drug squad of the police, the vice squad, the churches, the bishop, the archbishop, the media, the newspaper editors, and so on. And we were able to establish that coalition.
What AIDS has meant is that we have to do things that appear very, very controversial. And I think, fortunately, with the Merseyside police policy here, that the main reason we're keeping down the spread of the virus is the fact that the police support this type of activity.
It brings back many memories for me, this, because at that time we were so active doing different things in public health, but this one stood out among them as being the one that took off, got traction, got legs very quickly, got political support from across the political spectrum and made a difference, and then got picked up, not just locally and nationally, but globally. That's where the idea of harm reduction came from, of actually engaging with drug users, supporting them, looking after their physical health, because many of them finished up with amputations and septicemia, and obviously the death toll, which continues to rise even today. So this is the origin of what came to be known as harm reduction, and which went around the world because the Liverpool initiative was the first large-scale project. We didn't realise at the time just how significant what we were doing was.
I think it brings back a lot of memories for probably a lot of people in terms of that video. And people like John, a real pioneer of his day, weren't afraid to tackle some of the more stigmatised areas of public health. And I do wonder, where are our pioneers today? Where are the people who are going to lead us through the challenge that we are facing, as Deb outlined at the start of the session? It felt fitting being here today and kind of reflecting on the past to look at another pioneer, Russell Newcombe, who was a leading voice in the harm reduction movement in Liverpool at the same time, and he passed away earlier this year. This article that was in Drug Link in 1987, A High Time for Harm Reduction, was thought to be the first time the term was actually used in print. I'm going to read a kind of quote from his obituary, so if you kind of bear with me while I read it from this screen. And this was what was written in Transform around Russell. He was a singular figure in the UK drug policy field, a brilliant mind, a courageous and compassionate spirit. Russell dedicated his life and his career to the health, well-being and rights of people who use drugs, a community of which he was an unashamed and vocal member of. His pioneering research on responses to the new and intersecting crises of injecting drug users and HIV would go on to be the foundations of the harm reduction paradigm that now shapes much of the UK and global drug policy. I was really lucky when I was in Liverpool because I got to study under Russell at John Moores University when I did a master's, and his kind of enthusiasm and knowledge and passion for all things harm reduction really did shine through. And I think it came in the video earlier around what was different around the Mersey model is that it was the coming together of lots of different people. So it was public health, it was the council, it was police, really coming together to take a pragmatic approach to solving or trying to solve the crisis. And what was also really important is that it was shared. So the Mersey model was shared across the country. People came to see what was happening in Liverpool at the Maryland Centre and took that innovative practice back to their own cities and set up similar projects. And that's really what today's about. How can we collaborate more, share more, look at what each other's doing and take some of those ideas back to our own places of work. I'm having clicker malfunction. I'll try the other one. Bear with me. That's it. Thank you. So I joined Turning Point 12 years ago now, and it had a reputation as being a bit different as an organisation and doing things differently and not afraid to be innovative. And I thought, that sounds good. That sounds somewhere that I think I'd like to work. And this year, Turning Point does turn 60, and we've done a lot to reflect and to look at what's changed over the last 60 years, particularly in society and for the people that we support, people with a learning disability, with mental health issues and people who use drugs and alcohol. And a lot has changed. And over the decades, we've been involved in some really innovative practice, some quite cutting-edge practice at the time. And again, as we look to the threats that we've got today, with rising drug-related deaths and the emergence of synthetic opioids, we need to look again at the past and to look at what can work and what we might be able to do differently. So I'm going to go on a journey down memory lane. So we were founded in 1964 and we were called the Helping Hands organisation. And in 1969 we opened our first drug and alcohol service, the Camberwell service, and that was in South London. And it was about this time that heroin use started to go up. In 1971 we opened our first harm reduction service, and that was the Hungerford Centre in Soho, and we still deliver services across Soho today. In 1980 we opened the Rehabilitation of Metropolitan Addicts Project. Now obviously that's not something we would call a service today, but it was one of the first residential rehabilitation centres in the country. And again, being Turning Point, we try and make all our services as person-centred as we possibly can. And we think today it's one of the few rehabs that allows dogs to come in with people. And again, we're looking to expand that to other pets. But again, it's looking at what might be some of the barriers for people coming into to residential rehab, and having a pet can be one for lots of people. In 1983, we opened Drugline, which was a helpline for people who wanted advice and information around drug and alcohol use. And this was at a time where phone technology was just emerging, allowing us to do things like that. And it was also a time where lots of homes still didn't have a telephone. So I think it was about 80% of homes had a phone. So at the time, again, it was quite an innovative thing to do. And during the 1980s, we developed more tailored services for people. And it was at this time in 1981 that the AIDS outbreak was first reported. In 1987, our Metropolitan Addicts Project provided care for people with AIDS and HIV. And in 1991, the Griffin Project in West London that we ran became the first continuing care unit for people with HIV. Fast forward on today, and as Deb mentioned, in 2022, we hosted our first Safer Lives conference. We've also, over the years, played a small part in helping to change policy. And we took part in a study back in 2006 and 2007 with foil, to look at distributing foil through needle and syringe programmes. And 4 of our services in the southwest took part in the study, and were able to give out foil because the police said they wouldn't prosecute us. So we were looking at what impact that would have. And what the study found was that it really reduced risk-taking. And attracted more people into needle and syringe programmes. We found, I think it was a 32% increase in people using the programmes, and really importantly, people who'd never used services before, and people who didn't inject. And that study went on to form the body of evidence that changed the Misuse of Drugs Act and allowed foil to be distributed across all services in the country. This next quote is taken from the same study that was published in the Harm Reduction Journal. And I think it talks about the importance of workforce. It talks about the importance of having a highly skilled, highly trained, passionate group of people working in the sector. And I ask myself the question when I look at it, is where are our next generation of passionate, enthusiastic, highly skilled harm reduction practitioners? Where are they going to come from, and what's our role in that? Again, collaborating with people who are most at risk is how that we're going to innovate and make sure that the messaging is accurate, and empowering people with information that they can share amongst their peer group is also really important. We know we're not going to be in touch with everybody. We know there are lots of people for lots of different reasons that don't contact services. And this is Robin, who uses our service in Leicester, and he spoke to us about his experiences of the change in drug supply and the strategies that he uses to keep himself safe and those around him safe. We all need to make sure that we're all working with Robins across all of our different services to provide the right information so that they can share that amongst their peer community. So these are just some of the kind of other bits of work that we're involved in across Turning Point. We've got there, as you can see, we've got naloxone carriage boxes that we designed in our service in Herefordshire. And those were designed with people we support, our client group, co-designed, as all these kind of interventions were. There's a public-facing naloxone campaign that we've run across our services. And we're doing some work around adapting and enhancing training for young people in how to administer naloxone and what to do if they see somebody in an overdose situation. And I think we're going to hear about that from Dawn a little bit later. But I think what's really important is that they were co-designed, all those pieces, all these kind of pieces of work are co-designed with people who use our services. And again, that's got to be something we've got to do more of. Then, I wanted to end and where Deb started really with this slide, which shows the most recent drug-related death figures released at the end of last month. And as you can see for the graph, they're still continuing to go up. And I think there's a real danger of becoming desensitised to this. And we can't let that happen because we know each death is preventable. You know, we know that there are increasing risks out there, as we talked about with synthetic opioids, reaching people who, you know, are using all sorts of different types of drugs now, and it's putting more people at risk of overdose. You know, the Russell Newcomb article that I put up earlier, written nearly 40 years ago, is still accurate today. You know, it could have been written for today. It is still time for harm reduction. And I think as we collaborate today and talk to each other on our tables, I guess a question we could all ask is, what's my role in this? What's my role in helping to save more lives? Thank you.